Well, thank you very much for the kind introduction. I hope you can hear me okay. Well, greetings from New York City. My talk is going to be more dull, relatively dull, compared to these fascinating slides that you show in the previous talk. But it's very important. Although it's boring, it's very important because whatever we're going to talk today here, if your lab is not up to the quality standards, and if you don't control significant pre-analytical factors, then you have a problem. You have a problem because you're not going to get results that are actually meaningful or you can trust. And so you may be working on results that they are rubbish, or you may not be able to get the results that the patient deserves because they are there, but you can't actually prove it because a lot of pre-analytical factors have not been controlled. So that is very important. And as it was mentioned in the previous talk, we have moved in the 21st century when we are in the era of nucleic acid-based molecular tests for everyday clinical practice. I mean, we move forward with other tests as well. We start using methylation tests for tumors, etc. But for today's lecture, we're going to focus on nucleic acid-based molecular tests that are rapidly growing, and they're being used in different scenarios. I mean, I use nucleic acid-based molecular tests every day for diagnostic purposes, but of course, they're very important to the oncologists and other clinicians for predictive purposes, and they're extremely important for the patient as well because they can give you prognostic information. Now, for a lot of things that I'm going to talk in this small talk, I assume that most of the participants are clinicians. You haven't even ever heard of it because you may have not been in an anatomic pathology lab yourselves, what I totally encourage you to do and meet with the chair of the department that you're sending your specimens, so you get an idea of what kind of lab and what kind of quality standards they have. So it is routine in pathology practice that certain standards are being monitored very closely. And there are a lot of rules that are rigorously applied in labs that are certified, right? So one thing is you have to know what kind of certification your lab that you're sending your specimens has, right? I don't think public hospitals in Greece have any kind of certification. So some kind of quality control that somebody comes and inspects and say, okay, everything is up to the standards. So that is very important. But in normal circumstances, there are rigorously applied standards that they have to do with the analytical validity of the test itself, the quality of the laboratory in which the test is performed, the professionals do they get proficient in tests, so they can actually have the license to be able to sign out these cases, and that is relatively pretty common in standardized in pathology labs. However, there has been considerably less focus to the fact that the accuracy of the test results can actually be significantly compromised by what we call pre-analytical factors. And what are pre-analytical factors? There are procedures, there are practices and environmental factors to which the biospecimens are subjected before you actually have a laboratory analysis. And these are called pre-analytical factors. And they can have the strongest detrimental effect on the molecular side on patients' biospecimens. And you may be surprised by this, but some studies have shown that the pre-analytical errors constitute about 60 to 70% of all laboratory errors. So it's not the machine, it's not the bioinformatician, it's not the pathologist, it's not the oncologist, but it's factors before the tissue reaches the machine that actually can affect, and you can have false positive or false negative results. So the patient samples are collected, they are handled to the pathology through courier and other methods, and they are being processed in the pathology lab. And all these kind of process, there are so many steps that happens there who can be have a effect on the molecular quality and composition of the specimen. So for reliable and biological meaningful analysis, the integrity of the biospecimen must be safeguarded through critical steps that include the acquisition, the transportation, the stabilization, the processing, and the storage of the tissue. These are all important factors, not theoretically, but because can actually affect and can skew the data for molecular analysis and render the data uninterpretable or even preclude analysis whatsoever. So it's really important if the surgeon is operating in like a hospital, till the specimen from like a hospital to the anatomic pathology in the university or wherever they send them. There's a lot of factors till it gets actually into the machine. There's a lot of factors there that somebody has to regulate and keep the quality standards above a certain threshold, so you can actually have reliable results. And this is not something exotic. People have actually looked at this, and this will surprise you, but it's estimated in the United States that something very simple that happens in everyday practice, that false negative and false positive HER2 test results actually affect 12,000 patients with breast cancer annually in the United States, where the quality standards are so high. And they have calculated that the total economic societal cost from these false positive and false negative results is actually almost $1 billion. So it's just one test, which is supposed to be pretty straightforward. It shows you how complicated it is, and when we're moving to more complicated molecular tests. And currently in the United States, in Europe, Japan, Australia, everywhere, there are no requirements to control or record pre-analytical variables in clinical practice. The only difference in the United States, and I'm sure that is in Europe as well, that is breast cancer tissue, right? So breast cancer tissue, you have to record all the pre-analytical factors, and even that you can get false positive and false negative, as you see here. So if you have pre-analytical factors that play such a significant role, and they're uncontrolled and they are undocumented, you can see that the provenance of samples undergoing molecular analysis is essentially unknown. And that is for clinical labs. If we go to translation research labs, the situation is even worse, because the translation research labs, they don't routinely perform clinically mandated quality control that rigorously, as is the case in clinical labs. And you can see that the situation there is even actually more unknown in terms of pre-analytical factors. So people have recognized this problem, which actually can be quite big. And the College of American Pathologists, they start a big project, the so-called Precision Medicine Project. And they were trying to recommend practices that would ensure the molecular integrity of cancer patient biospecimens for precision medicine. And so they try to have evidence-based, all the literature review. So it's a big work, and provide recommendation for pre-analysis in tissue and blood specimens. And I'm going to focus on tissue because I am an anatomic pathologist. So there are a lot of factors, cold ischemia type. We're going to talk a little bit about that. That is from the time the surgeon gets the tissue out of the body till the tissue is fixated with formalin. What is the time there? That's called cold ischemia type. That can actually affect, as we see, the molecular the molecular background of the tumor. Genes are overexpressed, underexpressed, etc. Because till you fixate it in formalin, the biological events are continuing happening. What are you using for stabilization? What kind of you use formalin? What exactly you use? For how long do you actually fix a specimen? How do you process a specimen? How much do you cut it so you get adequate fixation? What kind of tissue processor you use? Do they maintain daily? Do they have quality assessment controls? How do you storage? If you're at a public hospital, do they have storage conditions that are very stable? Or, you're in the basement of Yanimatas Hospital in the summer with 45 degrees of Celsius, right? That will affect the molecular integrity of your specimen, subsequently the analysis of the specimen. So these are all factors that we need to record and we need control to the extent as possible so you can preserve the reliability of your specimens. So what is cold ischemia? Cold ischemia is different from warm ischemia. Actually, warm ischemia actually plays a role, but nobody documents that. And warm ischemia is by the time the surgeon clamps the vessels, so you can take the organ out till it takes the organ out of the body. That is warm ischemia. And that actually can affect the can have molecular consequences in the tumor. And nobody documents that. And there is a try with the College of American Surgeons to actually educate their members and see if we can actually go and document that. But that is later. We don't even document, except for breast specimens, the cold ischemia type, which the cold ischemia is from the time the tissue is out of the body till it goes to the bucket to be fixated. That is important, and that has to be 1 hour or less. And the reason is, till you fixate the specimen, all the biological processes in the tumor continue to be happening. They haven't stopped. So that can affect gene transcripts, which are likely to be upregulated within 2 hours of cold ischemia, and highly labile molecules like protein kinases and phosphoproteins, actually they can be affected much sooner, in 30-45 minutes. So people have studied that, and within 15 minutes of cold ischemia, up to 15% of tested genes and proteins change from baseline levels, and up to 20% of all detectable molecules change within 30 minutes, right? So you can see how fast things happen. And in relation to normal tissue, actually the neoplastic tissue, the cancer tissue, is even more vulnerable to the effects of cold ischemia. So that's very important. It has to be documented. And of course, it's difficult to control, but these are questions now after the talk. You go back to your lab, and you know, if you have a good relationship with your pathologist there, to actually discuss these things, so you can feel more comfortable that the right things are happening. And what is fixation? So the tissue is getting out of the body. Cold ischemia time, it still gets fixated. And fixated is we put it in a chemical, which most of the times is formalin. And that is a fundamental step for long-term tissue preservation, that you prevent autolysis and molecular components decay. Basically, you just stop the biological processes. And after you fixate it, after the tissue is fixated and you cut it and you put it in a tissue processing, then you put it in paraffin, which is wax, so you can cut it and have it in the blocks that the formalin fixated paraffin blocks. And we don't usually, you can use fresh tissue that doesn't have very often. So most of your molecular tests, they are actually in tissues from the blocks, from paraffin embedded formalin fixated specimens. So what kind of fixative they use? I mean, there are a lot of things that you can use, but we use neutral buffered formalin. 10% pH is recommended. Now, that's one thing that's important, but it's important actually to have a quality control about formalin as well, because if formalin is not checked regularly, it's very unstable chemical, and it can oxidize to formic acid. And so that's very important. So you have quality standards. If your lab is accredited by an organization, all of these are getting checked. If it's not, you're at the lab in the neighborhood, or some kind of molecular biologist open a lab in the suburbs in Athens with no accreditation, you have no idea, you have no way of actually knowing what's going on there. So what formalin does is fixates, basically induces DNA protein and RNA protein crosslinks, but also that actually random damages the DNA. So it's difficult, but we have the technology now to extract DNA and RNA, although it's more difficult in paraffin embedded tissue from fresh tissue, obviously, but it's being used pretty efficiently. But you have to understand that fixation per se can actually directly affect nucleotides, causing molecular degradation or alteration in sequences, right? So it has to be a particular time that gets fixated. We're going to talk a little bit about this, or changes in the pH can actually be detrimental to the molecular integrity of the specimen. So you should fix it more than 6 hours, but no greater than 36 hours for most tissues, or 48 hours for tissues with high fat content. Now, that is problematic in Greek hospitals because they are understaffed. So what happens, and I've seen that, I know that the surgeon sends the specimen, let's say it's the cold ischemia is less than 1 hour, you can question that. And then they're so busy that the tissue is sitting on the bucket for 5 days, 6 days till it gets grossed, right? And then, so that immediately will affect possibly the reliability of your molecular results. So ideally should be less than 48 hours. Especially if you actually do proteomics or immunohistochemical application, it actually should be less than 24 hours. So you really have to have a well-run lab, which is logistically a very challenging task because a lab doesn't have only your specimen, it has thousands and thousands of specimens. But that's how the labs should run, and that's why you have regulatory bodies to actually regulate, to give you accreditation that actually you can run the lab the same way that actually you can actually fly a plane. If you do RNA or DNA, can tolerate a little bit longer fixation rates, but these are actually the recommended timelines. Then, the person who's going to cut it, has he been trained, right? Does it cut big pieces of tissue, or they're actually more thorough? It's recommended to your slices do not exceed 4 or 5 millimeters. And then how much formalin you're going to put in relation to tissue, important. Formalin, it penetrates the tissue very fast, but it's actually the fixation process is actually slower and can be affected by temperature and other factors. So the recommendation is about 4:1. Now, formalin is cheap, so I don't think that would be a problem in a lab in Greece. It's not like it's very expensive, a private lab to try to cut the budget. It's cheap, but you have to follow ideally these kind of ratios. Now, the tissue processor maintenance, either people strictly adhere to manufacturer's maintenance. It's very important. For example, it's very important to control the alcohols. All these are expensive. So do they cut the budget, right? Do they cut corners because they want to be more profitable? Does someone regulate that? So you really have to be strictly adherent to manufacturer maintenance guidelines. And then what kind of paraffin you use low melt paraffin. I guess everybody will use that. And then storage conditions are important. Do you keep room temperature, 25 degrees of Celsius, or that's the recommendation? Who actually oversights that? And then you put it in wax paraffin, right? What permeates the tissue in a liquid form and then solidifies rapidly when you cool it down, so it's hard, and then you can cut it. That is the block that you all know and that you request from your pathologist to be sent for analysis. Now, paraffin removal is necessary for extracting pure DNA, but you have to be aware that you can have fragmentation, and especially RNA fragmentation is more common. And the longer the block, the older the block it is, you can actually have more fragmentation, and therefore the molecular analysis can fail. But we have improved technologically the last decade or so. So nucleic acid extraction methods are much better. The confounding effects of paraffin have decreased. I'm sorry for the horning, but this is New York City. Effects of decalcification. That's very important. Actually, our oncologists are fully aware of that here in Memorial Sloan Kettering. I get 10 bone metastases a day, right? And we don't decalcify everything, right? The oncologists will say 2 specimens, 1 do not decalcify. They actually are aware of that because they need the tissue to be molecularly analyzed by impact by our molecular platform, because they need this data to treat their patients. So are grossers, they're going to feel the tissue. If it's not too hard, they're not going to decalcify. That's very important. So the patient can have the NGS, because that is humongously very important in a metastatic lesion. Or if you're going to decalcify, make sure you don't use this hard decalcifier like nitric acid that you use for these bone resections. You can use softer chemicals like EDTA or formic acid that actually are molecularly friendly. So that is very important, because if you don't control that, if you don't discuss it with your pathologist, every bone biopsy you do, you're not going to get any result. And people have to have molecular analysis in their bone metastasis. This is happening here every single day. And the other thing is the age of sample, right? Let's say you have a patient and the molecular analysis wasn't done, but in the primary tumor now has a metastasis, you cannot biopsy, and you want to do a molecular analysis of the primary tumor that is a block in Soteria Hospital that is sitting there for 7 years, right? So that is important. The older the block, you may decrease your chances, but if pre-analytical factors are controlled, you actually may be successful to have a molecular analysis in an older block for even a 10-year-old block. Of course, RNA sequencing would be harder than DNA, but age of sample may or may not affect. And then is who's going to actually see the slide? And that is a problem in Greece, where molecular biologists have taken over the molecular analysis, because a pathologist has to see the slide. The slide doesn't contain pure tissue, pure tumor. It may contain fibrous tissue, non-neoplastic tissue. So it's very important, someone who is trained to see an H&E and circle the area of the tumor, and that's why you go and scratch it, and that too, so you get the DNA and RNA extraction. We don't do micro extraction in clinical labs. It's just too time consuming. Nobody does that. So you're going to scrape it with your blade, but someone has to see the slide and see, okay, here's the tumor. But if a molecular biologist is going to see a slide, he has no clue what he's looking at. So we actually have a mixture of various cells. So you dilute your DNA and RNA with non-neoplastic DNA and RNA, so it's called dilution effect, and you may get a false negative result, right? So that is very important. So in conclusion, reliable documentation of the pre-analytical history of patient specimens will enable a baseline level of quality for patient biospecimens where none currently exists, and it will further enable objective estimation of the fitness of a given sample for either real-time or future testing. And quality control is imperative. You have to get reliable and reproducible data. So it's urgent that pathologists and other medical professionals who are part of this quality chain of patient biospecimens to implement a coordinated, evidence-based approach to pre-analytics to actually meet the requirements of precision medicine. So when you get a result, you may have no choice, of course, to work on this result, but I strongly encourage you as oncologists to work closely with your pathology or molecular lab to actually try to establish this quality chain, so you're actually sure that you provide your patient the best service possible. Thank you very much.